Welcome to our lecture on Chapter 10, the endocrine system. The endocrine system can be a little bit complicated, and do realize that we are not endocrinologists, so our understanding of the system is going to be very basic, but having a little bit of knowledge here can help you understand a lot of why things happen in the body that otherwise would defy common sense. So, chapter objectives are to define and describe all bold-faced terms in the chapter, describe the physiology of the endocrine system, identify anatomic structures, and differentiate the various pathologic conditions. The physiology of the endocrine system is really a complex process. So it consists of a biochemical communications network through which several small glands control a broad range of vital body activities. And these activities can range from the breakdown of fats and lipids to metabolism to production of red blood cells in the control of a menstrual cycle to everything in between. So these major endocrine glands, also known as adrenal tissues, are pituitary, adrenal, thyroid, and parathyroid glands. Our pituitary gland is located in the sella turcica of the cranium. It is also controlled by the hypothalamus and has an anterior and posterior component. The adrenal glands are two separate glands that are little pyramid-shaped glands that are superior to the superior pole of the kidneys. They're prominent in fetuses and newborns, but they're really difficult to identify in adults because of their small size. The thyroid gland is located in our neck on the anterior aspect and drapes over the trachea. And the parathyroid glands are arranged posterior to the thyroid glands, with one parathyroid gland typically in each of the four lateral margins of the thyroid gland. The whole purpose of our endocrine system is to secrete hormones. So our endocrine system is stimulated by different chemical messages that affect and target specific organs to release particular chemicals at a specific time. And those specific chemicals that are released from our endocrine organs are going to have a function that they go out and they travel to other organs in the body, and then they stimulate the other organs in the body to complete that function. Some of the hormones that are excreted by the endocrine glands are proteins, steroids, peptides, amino acids, and amines. They range from all very small to large molecules depending on their makeup and their function. Physiology of the diseases. So as we look at the separate endocrine glands, we're going to find that each gland is going to have its specific physiology and its specific function and its specific target areas that its hormones are going to affect. So the adrenal glands, like I mentioned, sit atop of the kidneys, and they are, again, quite small and they're pyramidal shaped. They consist of an outer cortex and an inner medulla. The outer cortex is going to secrete one series of hormones, while the inner medulla is going to secrete a second series. The adrenal cortex secretes several different types of steroids, and these steroids can be divided into three different general groups. The first is the mineral corticoids, which help regulate salt and water balance. So these mineral corticoids really act often on the kidneys to tell the kidneys exactly what it needs to resorb out of the urine production and what it needs to allow to be excreted throughout the kidneys. Another type is a glucocorticoid, and this regulates carbohydrate metabolism. And then finally, there's a group called the androgens. Now, the androgens are sex hormones, and androgens typically tend to masculinize people. So, of course, a male would typically have additional androgen secretion. Now, sometimes there's going to be certain diseases that affect a female that can cause them to take on more male gender characteristics, such as increased abdominal fat, hair on the face, alopecia or loss of their hair on their head, things like that. And lots of times it's from the androgens that our adrenal cortex is releasing. The adrenal medulla, on the other hand, is internal to the adrenal cortex, and it secretes epinephrine and norepinephrine. So these are our hormones that are going to control our fight or flight reactions to things. They're secreted in stressful situations. So as you've all been scared and you felt that rush of adrenaline where you wanted to run, that is when your adrenal glands are stimulated at the medulla to release these epinephrine. Epinephrine, when released, stimulates your heart activity, raises your blood pressure, and increases the level of blood glucose. And by doing those three things, it prepares the person to flight, to run. So that high glucose, that high sugar content is going to elevate metabolism abilities. The heart rate is going to increase ability to provide oxygenation throughout the whole body, and the increased blood pressure is going to help with that as well. So epinephrine stimulates that flight response. It also shunts blood to active muscles where oxygen and nutrients are urgently needed. And by doing so, it constricts the blood flow to the other organs. So in our everyday activities, our body typically make sure that our brain, our liver, all of our internal organs that are doing the constant work of our body are provided with oxygen and nutrients first. And then the rest of our muscles and other tissues are kind of an afterthought. If there's available blood, then it dilates those vessels and those parts of our body get the blood. Most of the time, it's able to suffice and provide blood flow to all areas. Now, epinephrine kind of causes the reverse reaction. So under extreme stress, the vessels to our internal organs may constrict. It can put digestion on hold. It can put kidney function on hold by restricting that blood flow and shunting all of that extra blood to our muscles so that we can flight or run if necessary. So there can be numerous different diseases of the adrenal cortex where that outer layer of the adrenal gland actually ends up secreting an abnormal amount of hormones. And those abnormal levels of hormones are going to affect how the body works. So with Cushing's syndrome, this is an excess secretion of the glucocorticoid cortisol. Now, when cortisol is produced in excessive amounts, it causes an increase of adipose tissue development or collection around the trunk of the person. It also can cause weakening and deterioration of the arms and legs. So these patients would have a very large trunk with very thin arms and legs. Now, the reason Cushing syndrome occurs is going to be dependent on the cause of the excess cortisol in the system. If the patient is intaking cortisol hormone, then the Cushing syndrome could be addressed by decreasing the hormone intake. However, if the excess cortisol is due to some sort of tumor in the adrenal cortex, then that tumor would have to be addressed to address the Cushing syndrome. The other type of adrenal cortex malfunction is called aldosteronism. Now, aldosterone is produced by the adrenals, and the aldosterone basically goes and acts on the kidney, and it controls the amount of water and electrolytes that are pulled from the collecting tubules of the kidney back into the circulatory system. Now, aldosterone can be stimulated for release in a number of different ways. One of the ways it can increase its release is by having an excretion of renin in the kidneys. Now, when the kidneys note that the blood pressure at the kidney is lower than expected, it would stimulate the production of renin. Renin would, through a process, go on to stimulate the production of aldosterone, and then that aldosterone would cause more resorption of fluids and electrolytes from those kidneys into the bloodstream to increase the blood pressure. That would be one way that aldosterone or aldosteronism could occur. A second way would be is if there is actually a tumor in the cortex again that was just causing the excessive secretion of aldosterone for no reason. And this could be cause for an increase in blood pressure due to that fluid accumulation in that it would stimulate into the bloodstream. Here's an example of a patient with Cushing's syndrome. Arrows are pointing to the cortical edema. So usually our cortex is a little bitty pyramid-shaped structure, something like that might look a little bit like this on a CT at top of the kidney. But you can see here that this is a very enlarged edematous uh, adrenal gland, which is demonstrating the problem for causing this Cushing's syndrome is going to be an adrenal mass rather than the use of corticosteroids. Another disease of the adrenal cortex is androgenital syndrome. And this can be congenital or it can be acquired. Now what this is some androgenital syndromes would be a chromosomal defect that caused maybe a female to secrete extra androgens or a male to secrete extra androgens. And it would be tied to the genetics of the person. And whenever we have extra androgens, we're going to have more of a display of male characteristics. There's also an acquired form of this in which it could be a tumor of either the ovaries or of the adrenal gland or something like that would be causing additional androgen secretion. So anytime you see androgen, I want you thinking of male characteristics. So if a female were to have excessive androgenital syndrome, then they would have possibly anovulation or no ovulating. They could have amenorrhea, no periods. They could have difficulty conceiving. They might demonstrate a decrease in breast mass, an increase in abdominal fat. Hirsutism, which is the male characteristic facial hair with more acne and a decrease in hair on your head. So that would be all androgenital syndrome. We're taking on more male type secondary sex characteristics. Hypoadrenalism is adrenal insufficiency, and this is where the primary adrenocortical production is decreased and insufficient, and it's known as Addison's disease. So those adrenal hormones that should be being released are not being released, and some of this can be due to the use of steroids over time. Because you're implementing or you're putting those steroids in your body, you take some of the pressure off of your adrenals to perform, and then eventually they'll stop performing, and that can lead to hypoadrenalism. Other types can be caused by tumors or just other sort of infarct reactions or other types of diseases, which would just basically reduce the production of adrenal hormones. Adrenal carcinoma is relatively uncommon. It is a primary malignancy of the adrenal gland, and about half of the carcinomas result in the following syndromes. So Cushing's syndrome could be caused by an adrenal carcinoma. We talked about it having a tumor in the cortex could lead to excessive cortisol release. Sometimes that tumor causing that excessive cortisol release would be an adrenal carcinoma. Now, carcinoma always means malignant. Virilization would be changes in the sex hormones. Feminization would be changing in taking less of the male sex characteristics and converting towards a female sex characteristic. So this could be the opposite of androgen release. It would cause breast development in the male patient, change in emotion, loss of facial hair, softer skin, things like that. And then aldosteronism, which we talked about, could affect the blood pressures by affecting what was resorbed at the kidney nephron level back into circulation, changing the blood volume and effectively changing the blood pressure. Adrenal carcinomas, if they are present, typically grow really rapidly, and because they grow so rapidly, they can outgrow their blood supply, which would then result in large necrotic masses of tissue that's dying off because there's not enough blood to support it. So here is an example of an adrenal carcinoma. So you see, again, the adrenal should look something like a little wedge pyramid shape on top of the kidney. And here you see, as far beyond a wedge is a large mass of mixed densities on this CT exam. And when biopsied, this comes back as a renal carcinoma, an adrenal carcinoma. Now, adrenal metastasis is one of the most common sites for metastatic disease. So we can have primary cancers of the lung, breast, kidney, ovary, GI tract, and melanomas or skin cancers. All of these can easily metastasize to the adrenal gland. Here's an example of a right-sided metastasis to the adrenal gland. So here's the kidney, and you see the adrenal gland is actually just anterior to it at this level, but would go superior to it as well. Oh, actually, okay. So if you want to review all of these different cortical abnormalities for your adrenal glands, here's a brief chart. That brings us to the inner component of the adrenal glands, called the adrenal medulla. One of the more common malfunctions or diseases of the adrenal medulla is called pheochromocytoma. And this is where a tumor that's mostly in the adrenal medulla develops, and it causes an increased release of a vasopressor substances, epinephrine and norepinephrine. These can cause uncommon but curable forms of hypertension. So CT and ultrasound can be used to demonstrate a pheochromocytoma, and really this would often be identified on a CT or an ultrasound, but really the clinical presentation of having changes in blood pressure are really going to be some of the first indicators of this disease. Here's an example of a pheochromocytoma on the left kidney here. So this would be the mid left kidney over here. And obviously this would extend to the superior left kidney as well. Here is one demonstrated on an MRI. So you see it's just superior to the kidney here. All right, another disease of the medulla is called a neuroblastoma. This is a very highly malignant tumor that originates in the medulla, and it's the second most common malignancy in children. It tends to get very large before it's detected, and it can be confused with a Wilms tumor, which is a childhood tumor of the kidney. So one of the ways that you can differentiate a Wilms tumor from the neuroblastoma is by the calcifications in the tumor. So here's an example of just a general radiograph, and here is a large mass containing many, many small granular type calcifications indicative of a neuroblastoma. So our adrenal medulla can have diseases such as the pheochromocytoma, which causes excessive epinephrine and norepinephrine, and we know that epinephrine and norepinephrine can control our vasoconstriction, increase our blood pressure, cause excessive heart rate, so on and so forth. So if we have this pheochromocytoma and we're excreting excessive levels of epinephrine, norepinephrine, you're going to be in a constant state of feeling like you're in fight or flight. A neuroblastoma, this is our childhood tumor of the adrenal medullary region. It can be identified on a number of different imaging modalities, and it's usually treated with surgical resection in addition to chemotherapy and radiation. That brings us to physiology and diseases of the pituitary gland. And like I mentioned before, the pituitary gland is that little gland that is going to sit, if we're looking at our lateral skull x-ray, and we have a sella turcica right here, our pituitary gland sits right in that sella turcica. So when we're looking at our lateral skull x-rays, we really want to be looking at that sella turcica, making sure that it doesn't look enlarged, degraded, or abnormal. Okay, so the pituitary gland sits in our sella turcica, like I said, and it's called the master gland. And really, if we think about a lot of our endocrine processes, they occur in basically a 1, 2, 3 pattern. So lots of times, the first action in a hormonal reaction is often controlled by something called the hypothalamus. So the hypothalamus will detect levels of hormones, and when it detects lower levels of hormones or that a change must be made, it will usually produce a hormone that goes to step 2. Step 2 is really our pituitary gland for many, many actions in the body. Not all, but many hormonal actions. So step 2 is the hypothalamus stimulates the pituitary gland, and then the pituitary gland stimulates the organ that is able to accomplish the task. So, pituitary gland in that way is called the master glands. Its hormones secreted by the pituitary gland control most of the glandular activity throughout the whole body. However, it's not number 1, it is number 2. The hypothalamus controls what the pituitary gland does. Now, the pituitary gland, like I said, is a tiny gland suspended from the base of the brain by a slender stalk called the infundibulum. It sits in that sella turcica, and it's divided into an anterior and posterior portion. Each part, the anterior part or the posterior part, are responsible for their own hormones, and their hormones at the different parts are unique to that particular. So that pituitary gland that's divided into the 2 lobes, its anterior lobe is really going to be responsible for a number of actions. It produces thyroid stimulating hormone, or TSH. That TSH travels to the thyroid and actually causes it to secrete T3 and T4. It produces adrenocorticotropic hormones like aldosterone that is going to go to the kidneys and act on them. It is also going to produce gonadotropins, and gonado has to do with our gonads, and these specific gonadotropins that it produces are follicular stimulating hormone and luteinizing hormone. Follicular stimulating hormone causes the production of follicles on our ovaries, whereas luteinizing hormone causes the ovulation of our ova. Now, if the pituitary gland is not functioning properly, it can have a number of different problems. So one of the problems it can have is hyperpituitarism, hypopituitarism, or diabetes insipidus. So hyperpituitarism means that the pituitary gland is overproducing. So it might be secreting excessive levels of aldosterone, TSH, or those gonadotropins like follicular stimulating hormone or luteinizing hormone. Sometimes hyperpituitarism can be caused by a tumor in the pituitary gland. Other times it can be caused by other types of stimuli, whereas hypopituitarism could be caused by necrosis of the pituitary gland or just a lazy gland, and this would result in decreased levels of TSH, aldosterone, your FSH, and your luteinizing hormone. Finally, there's diabetes insipidus, and diabetes insipidus has nothing to do with sugars, believe it or not. Diabetes insipidus is a result of low aldosterone production. And because there's low aldosterone production, the kidneys don't go and retrieve a lot of the water and electrolytes out of the nephron tubes like they should. And because of that, excess urine is going to be produced. So these patients with diabetes insipidus are always thirsty, they're always urinating, and they're having trouble to maintaining homeostasis and their blood levels. Hyperpituitarism, like I said, another thing that it can cause is an excessive production of growth hormone. So the pituitary gland is responsible for growth hormone, and if it is produced excessively after the epiphyseal plates are produced, the long bones can no longer grow. So these patients will get very, very large, but at a certain point, their long bones won't grow any farther, so they'll start growing in certain areas where bone growth is still possible. Because of this, they will have something called acromegaly. And so acromegaly will happen when a patient, their long bone epiphyseal plates have fused, but certain bones like their forehead, their jaw, their hands can continue to grow. And because of this, as adults, if you have hyperpituitarism as an adult, you are develop the abnormality called acromegaly. If you have hyperpituitarism as a child, where excessive growth hormone is produced before your epiphyseal plates are fused, then it would cause excessive growth or gigantism even in the long bones, as well as your other flat bones or facial bones, like with acromegaly. And there's a number of different people that they guess probably had acromegaly or gigantism, like Andre the Giant, the wrestler, or a couple other actors that I'm having trouble thinking of their names right now. Another thing that acromegaly can demonstrate is a thickening of the tissue on the heel. So here you see the calcaneus, and here you see a very thickened skin line to that heel. That can be an indicator of acromegaly. Here you see something called frontal bossing, where most of the sutures are fused and the epiphyseal plates are fused, and yet certain areas of bone can continue to grow. And right here in front of the frontal sinus, you can see this additional growth causing what we call frontal bossing, or a big forehead, and appearance for acromegaly. Now, hypopituitarism, as we mentioned, is the opposite end of this spectrum. So this causes profound generalized disturbances in bone growth and maturation because of decreased levels of pituitary production. So some of this can result in a type of dwarfism. Now, this is not the dwarfism like achondroplasia that's associated with a genetic malformation. This is just an hypoactive pituitary gland reducing the release of growth hormone, causing the long bones and other bones to grow at a slower, reduced level. So most of these bones do not grow to a normal length. The patients end up small in stature. They they have sexual immaturity appearances, so those secondary sex characteristics don't necessarily come at a normal time. However, most of them are very well proportioned, unlike the chromosomal dwarfisms, and they have a normal mentality. Diabetes insipidus, as I mentioned, is completely unrelated to diabetes mellitus, which is related to our blood sugars. With diabetes insipidus, it is an impaired ability of the kidneys to conserve water. That's because we have a low release of antidiuretic hormone, and that antidiuretic hormone does not allow for the kidneys to pull a lot of the fluid out of the primary urine produced in the nephrons before excreting the urine. So a lot of fluids are lost through urine that would otherwise be resorbed if antidiuretic hormone was released in an appropriate time. Other types occur when kidneys fail to respond to the circulating antidiuretic hormone, or when there's aldosterone changes. And I'll let you review the summary of findings for the diseases of the pituitary gland. That brings us to physiology and diseases of the thyroid gland. We know our thyroid gland is on the anterior portion of our neck, draping over our trachea. It's butterfly shaped. just below the Adam's apple, also known as the thyroid cartilage. It consists of two lobes connected by one strip called the isthmus, and is responsible for producing hormones that are released into our system that control metabolism. The two hormones that the thyroid gland secretes is thyroxine, T3 or T4. Now, the difference between T3 and T4 in thyroxine to become active must connect with iodine. And to create T3, the thyroxine must connect with 3 iodine atoms, whereas with T4, it must connect with 4 iodine atoms. So, the thyroid gland secretes thyroxine as T3 or T4, where the thyroxine is associated with 3 or 4 iodine atoms. That thyroxine goes and acts on the body and stimulates cellular metabolism in response to the body's needs. It also increases the secretion of digestive juices and movement of ingested material through the intestinal tract. So, when we have abnormal levels of T3 and T4, that's when we're going to get abnormal metabolism in the body. Now, the thyroid does not act on its own. The thyroid is stimulated by the pituitary gland. That anterior pituitary releases thyroid stimulating hormone, or TSH. That TSH travels to the thyroid, and once it is at the thyroid, it causes it to produce and release T3 and T4. As T3 and T4 levels get high enough, then the hypothalamus detects those elevated levels, and it would signal the pituitary to stop releasing thyroid stimulating hormone. When the thyroid stimulating hormone decreases, then the release of T3 and T4 will decrease. Now, the thyroid is known for its many different possible nodules or masses. Nodules are masses that can be hyperfunctioning or poorly functioning, meaning it's an area of the thyroid that either produces too much T3, T4 or too little T3, T4. Now, if we're looking at a nuclear medicine study, we can give patients something, a radioactive nuclide that's laced with iodine. And because it's laced with iodine, it's going to rush to all the active components of the thyroid, because the thyroid's going to want to utilize that iodine to make T3 and T4. If we see hyperfunctioning areas of the thyroid, we will see an excessive amount of that radionuclide in that area. If we see, and those would be called hot areas. If we see areas where the thyroid is not utilizing iodine to make T3 and T4, we would call those cold areas, and they'd be non-functioning areas. Hyperthyroidism, like I said, is the overactivity or excessive thyroid hormone in our blood system. This can be termed Graves' disease if the entire gland is affected. Now, hyperthyroidism doesn't mean just the whole thyroid is always effective. It can come from a number of different causes. There can be an area of maybe an adenoma, that particular area is a hypersecreting area, or it can be the whole thyroid. So anything that's releasing excessive T3 and T4 would be considered hyperthyroidism, and it's going to increase the metabolism. And because T3 and T4 act on everything from our intestines to our cellular turnover, it's going to cause a lot of physiologic changes in the patient. So lots of times they'll have significant weight loss, they'll have diarrhea because of the increased bowel peristalsis. All of that increase in metabolic rate increases their heat production. That heat production must be eliminated from the body, so the patient will have excessive sweating or diaphoresis, and they'll often have a high heart rate. And if this is left uncontrolled for a long period of time, it can have a toll on that heart from working so hard for so long. Now, hypothyroidism, on the other hand, is a decrease in T3 or T4 levels. Hypothyroidism could be caused by a number of different issues. Perhaps the pituitary gland is not producing enough thyroid stimulating hormone. A normal thyroid in that case would cause hypothyroidism simply because it's not being stimulated enough. Another thing could be a lot of cold spots or non-functioning masses on the thyroid itself. That would reduce the function. One type of hypothyroidism that affects children and infants is creatinism, and this is congenital hypothyroidism. And congenital hypothyroidism, because the thyroid is responsible for mental development as well as metabolism, creatinism can cause multiple different abnormalities. It can cause a short stature, coarse features, a wide protruding tongue, a broad flattened nose, widely set eyes, sparse hair, dry skin, and a protuberant abdomen with umbilical hernia. It can also cause slow mental development. Now, a goiter, on the other hand, these used to often be caused by a lack of iodine. And the lack of iodine would cause low T3, T4 levels. And so our hypothalamus would detect that, and the hypothalamus would stimulate the pituitary gland to create more TSH. The TSH would act on that thyroid, but the thyroid didn't have the iodine to make T3 or T4. So it would continue to grow larger and larger in hopes that it could meet the need, and that would produce a goiter. Now, because iodine is mixed into a number of different household items that are very common in our diet, goiters from iodine levels are not as common. However, a goiter can still occur in a gland that does not result that does not result from an inflammatory or a neoplastic process. It can just form. Perhaps the TSH is so high that the T3, T4 it produces cannot meet the demand. So again, the thyroid may produce a goiter. Okay, some common other glandular diseases or masses is the thyroid adenoma. Anytime we see adenoma, this is a glandular adeno, and oma is tumor, so a glandular tissue tumor. These are typically benign, well encapsulated. They vary in size and appearance. They can compress adjacent tissue, causing a halo type appearance around them. And they can even be so large that they can cause deviation or compression of the trachea. Calcifications in these masses are not uncommon, and again, they can have a wide range of appearances. Now, thyroid carcinoma is the malignant counterpart to this adenoma, and there's three major types of the thyroid carcinoma. They're papillary, follicular, and medullary. The problem being here is that these two may or may not look alike. So when we're finding masses in the thyroid, and they have specific appearances that are not that unique to their particular benign or malignancy, then we have to really look at those and often do a fine needle aspiration or something of the sort to determine if they are truly benign or malignant. All of the thyroid carcinomas that are going to be malignant are going to be more common in our female patients. The three different types are papillary, which is the most common, follicular, which is slightly less common, and then medullary, which is the rarest of the options. Here is an example of a nuclear medicine study that demonstrates a hot spot on the right thyroid inferior lobe, and you see that right lobe is much larger than the left, and this hot spot in this case is an overactive tumor, which is causing hyperthyroidism. Here's Graves' disease, where you see the thyroid itself is diffusely enlarged, and so it's the overall thyroid that is producing excess T3 and T4 levels, resulting in hyperthyroidism. Here is an example of a goiter on a radiograph, and you see that this goiter is so enlarged that it is actually diverting the trachea to the patient's left side, which is not totally uncommon. Here is a thyroid adenoma. Thyroid adenomas, this is kind of an extensive example, but they can take on a number of different calcifications and other appearances. So this probably has areas of necrosis, areas of calcifications, and has grown quite large in this patient's neck. This could only be differentiated from a carcinoma through some type of biopsy. Most of the time, you're not going to see thyroid malignancies or thyroid pathologies on your x-rays, but it can occasionally demonstrate some, especially with calcifications. Here's an example of an ultrasound image of a papillary carcinoma. So this right in here is the nodule itself. It has some areas of fluid, which are black areas, and some septations here, which are going to be solid tissue areas. And it's kind of arranged in a spoke and wheel pattern that can indicate papillary carcinoma. Again, this alone would not be able to determine definitively what type of nodule this is. It would take a biopsy to determine if it was malignant or benign, which this one turned out to be malignant. Follicular carcinoma, here's an example. Again, it can have a number of different appearances, but this has a mostly anechoic center, which is representative of fluid typically, with this abnormal tissue growing around the periphery. And again, once biopsied, it was determined it was follicular carcinoma. That probably is not something that they would be able to determine from the ultrasound alone. So here's a quick summary of the findings of diseases with the thyroid gland. You can take a quick look. Most of these diseases can be treated if they're hypothyroid. They can be treated by giving oral hormones. If they're hyperthyroid, ablation or radiation treatments or surgical removal might be necessary. Reviewing the types of treatments for these may be beneficial. That brings us to our parathyroid glands. So our parathyroid glands are those four little glands that are located posterior to the thyroid glands. And our parathyroid glands are primarily known for their role in controlling calcium levels within our bloodstream. And if you remember from anatomy and physiology, calcium levels are essential for muscle contractions amongst other bodily functions. And so it's really important that we have adequate calcium within our bloodstream. However, on the other hand, our parathyroid hormones can cause the release of this calcium through our bones. And over-release of calcium through our bones is going to cause permanent damage to our bone density. So it's a fine balance that these parathyroid glands have to maintain to keep adequate calcium in our bloodstream without depleting our bones. So parathyroid gland physiology, like I mentioned, there's four tiny glands, two on each side that lie behind the upper and lower poles of the thyroid gland. They're going to secrete the hormone parathyroid hormone, or parathyroid hormone, or PTH. That PTH, like I said, regulates calcium and phosphate levels in the blood. We know how important those are. Now, hyperparathyroidism is when there's an excessive secretion of the PTH, causing excessive calcium and phosphate in the blood system. Part of the problem with this is not just the excessive calcium and phosphate in the blood, but it's that our bones pay a cost. The bone metabolism is usually breaking down, causing elevated levels of calcium and phosphate, but degeneration of the bone. Now, there's three forms of hyperparathyroidism, or three reasons that our parathyroid glands would secrete excessive levels of this hormone. The first is caused by a tumor in the parathyroid itself. The second, which is the most common, is associated with chronic renal failure. And because of the chronic renal failure, different hormones such as renin, aldosterone, and a number of different other endocrine hormones cause an imbalance, which would result ultimately in excessive parathyroid hormone release. The third is tertiary, and this is development of autonomous functioning of the parathyroid glands in patients who demonstrate progressive bone disease in the presence of biochemical and clinically controlled renal disease. Now, on the other hand, we can have hypoparathyroidism, where our parathyroids often due to injury or accidental removal during a thyroidectomy, can cause the reduction and release of parathyroid hormone. This causes the reduction in calcium and phosphate in the circulatory system. When we don't have enough calcium, we cannot support sustained muscular contraction. Now, our heart is going to be maintained as long as it can, so first symptoms are going to appear as muscle cramps in the hands, feet, and legs. It can also result in numbness and tingling of the extremities, or spasm in the laryngeal muscles and causing fatal obstruction of the respiratory tract. So the body is really going to maintain that calcium for the heart, so that as long as there's any calcium in the system, that is going to be the last that it has a reduced level to. So you'll see symptoms of this move from the extremities more internally to finally the respiratory system and the cardiac system, and then that can result in death. One of the things that you will see with hyperparathyroidism, if too much parathyroid hormone is being released, it's going to cause the excessive breakdown of bones to release that calcium into the bloodstream. And one of the things that you see when you see that on a radiograph, you can see these changes in the middle phalanges of the hand, because that is one of the first areas that's going to start to lose some bone mass due to hyperparathyroidism. Now, if it goes on and on and on, you can see that actually the tibia is a common place for this the bone to be destroyed to basically mine that calcium to maintain muscle function. And you can see this is basically not just the tibia, but it's even extended into the femur in this case. They can be very difficult to differentiate from a general bone cyst or a bone tumor, but by looking at the blood calcium levels, they would be able to determine that no, it was probably a parathyroid problem versus a bone problem. One of the things that can result of that is because of that bone thinning, then you can definitely have some pathologic fractures that would draw attention to the bone and possibly the disease. So here's a summary of the findings for the parathyroid glands of diseases. So we can have hyperparathyroidism, hypoparathyroidism, pseudo-hypoparathyroidism, which is the parathyroid hormone, or the parathyroid is still producing the hormone, but the hormone target organs are not responding to it. So it would not be a problem of parathyroid function, it would be a problem of the target organ, and that's why they call it pseudo-hypothyroidism. All right, that brings us to diabetes mellitus. And so we know that the pancreas is another one of our endocrine organs. And the pancreas has an exocrine and an endocrine function. And its endocrine function is the production of insulin by the cells called islets of Langerhans. Islets of Langerhans produce insulin and secrete it into the bloodstream. Now, when our body recognizes that there's high levels of blood sugar in our bloodstream, the islets of Langerhans are going to work hard to produce that insulin, and then the insulin is going to be secreted into the bloodstream. Those insulin hormones are going to interact with glucose and help get it absorbed out of the bloodstream into the cells. Another thing it can do is help it be converted to glycogen, which can then be stored into the liver. The other thing that the pancreas does is produce something called glucagon, whereas when blood sugar levels get low in the bloodstream, it can release glucagon that goes and acts on those stored glycogen supplies and breaks them down back into glucose to release them into the blood system. Now, the problem that can happen is if the pancreas is not secreting adequate values of insulin to administer or move that insulin out of the bloodstream into it into the cells, then we have excess sugars in our bloodstream. Those excess sugars, with the lack of insulin, deprives the cells uh, of the glucose that they need for energy. It also allows elevated levels of glucose in the bloodstream, which can cause irritation to the vessel walls and ultimately lead to plaque and arteriostenosis. Now, having excess blood sugar with insulin that can't keep up and move it into the cells is called hyperglycemia. Complications of diabetes, like I mentioned, is atherosclerosis. This is hardening and building up of plaque on the vessels because of that rough sugar rolling through the vascular system, causing roughening of the vessel walls, which leads to plaque accumulation on them, which leads to hardening and narrowing of the artery itself. Now, that hardening and narrowing of the artery can lead to a reduced amount of blood perfusion, which can lead to myocardial infarction in the heart if the blood perfusion to the heart is reduced, stroke if it's reduced in the brain, or gangrene if it's reduced to any tissue to the extent that the tissue dies and necroses. Diabetes can also lead to frequent infections because people with diabetes heal poorly because of their poor circulation. It can also lead to kidney damage and failure, again due to poor circulation as well as due to those harsh sugar crystals basically moving through the renal system, causing damage to it that way. It can cause narrowing and rupture of those tiny retinal vessels of the eyes, which often leads to blindness in diabetics. And it can cause poor circulation to the nervous system, which may cause a lack of sensation, especially in the extremities, or tingling sensation. This can often lead to wounds that patients don't feel, and which would then lead to poor healing of that area, which can then lead to gangrene, which often leads to eventually amputation of extremities. So diabetes mellitus is a very serious complication. It can have, you can have two types of diabetes. It can be type 1 and type 2. Type 1 is juvenile diabetes that's often stimulated by some sort of abnormal infection at a young age that causes the pancreas to stop functioning as well, whereas diabetes type 2 is usually caused from basically overworking your pancreas. So eating unhealthy, exposing your body to high levels of sugar, and then letting them plummet, and then high levels of sugar or constant high levels of sugar where it just can't keep up. The pancreas kind of gives up and loses some of its function. One of the last complications of diabetes is insulin shock. So this is when the insulin is high enough that it has, in trying to control sugars, that your blood sugar has gotten so low, it can cause a shock to the system because too much insulin has moved all of the sugars into the cells, and then all of the cells have used up those glucose and has no additional basically fuel, which can put the patient in shock. Complications, like I said, from diabetes, it really, here you can see the arteries of the hand having arteriosclerosis, a bunch of plaque settling in on the walls. Here they are in the wrists. Here you can see a foot with necrotic changes. This is probably a gangrenous foot. You see the destruction of the tissue with emphysema or emphysematic air collections within that tissue, indicating necrosis due to infection, due to poor circulation because of diabetes. So summary findings of our diabetes mellitus, you can take a look over that. And finally, a review question. Which of the following is caused by hyperthyroidism? Graves' disease, Cushing's syndrome, cretinism, or gigantism? and this is Graves' disease. It's usually an autoimmune hyperthyroidism affecting the whole thyroid. Which gland produces the fight or flight hormones? This is going to be our adrenal gland in the adrenal medulla. That is our epinephrine and norepinephrine. Which of the following causes acromegaly? This is the enlargement of the hands, jaw, forehead. So this is due to excessive secretion of the growth hormone, which comes from the pituitary gland. So this is hyperpituitarism. Well, thanks for sticking with me through this lecture. You're getting close to the end of the course, so I want to congratulate you for doing this all online, which I know is a huge challenge. And I hope you have a wonderful day, and we'll finish up with you in just the next couple weeks.